several years, we've done this Pediatric Neuroscience Day in honor of Dr. Humphreys. And today, as we were just talking about before we started, it's slightly different because of COVID-19 restrictions. And so, um, you know, we want to highlight, obviously, the combination of clinical and research that goes on. And so in just a second, I'll speak with Dr. Banwell, speak about Dr. Banwell, who I think highlights this. So in terms of the changes for today, though, obviously it's going to be all virtual. And over the past couple of years, a significant aspect that really I think we liked, our guest speakers liked, and I know Dr. Humphreys liked, was the ability to interact with our trainees, hear the research going on, give them feedback about what's going on. And we did that through a poster session in the past, excuse me. But we thought, sorry, one sec. But we thought that today we'd actually let them do presentations. And then I've asked kind of offline Peter and Dr. Banwell to provide them with some feedback afterwards. And then we're going to hear some talks then after about a 15-minute break. We'll have about a 15-minute break after Dr. Banwell's presentation, and then we'll hear talks from various trainees doing research in pediatric neuroscience and with neurologists at CHIO. So it's really my great pleasure to introduce Dr. Banwell today. She is a professor of pediatrics and neurology at the Perelman School of Medicine at the University of Pennsylvania and the chief of child neurology at the Children's Hospital of Philadelphia. She serves as the co-lead of the Neuroimaging program, an innovative age span program that focuses on multiple sclerosis, MOG-associated disorders, which many of you may not have heard of, but we certainly have in neurology, and you're going to be hearing a lot more about that today, and autoimmune encephalitis and other inflammatory neurological conditions in adults and children. Dr. Banwell has over 300 scientific publications and has chaired over 50 international courses focused on pediatric demyelinating disease. She leads a multi-site North American prospective study of clinical outcomes, genetics, immunology, and neuroimaging features of MS in children. Many of us at CHIO have participated in this prospective study. She's published studies focusing on the clinical characteristics of MOG-related disease in children and the MRI features of this disease, and she's served as a lead author on an international consensus document relating to autoimmune encephalitis, and leads the Autoimmune Encephalitis Working Group at the Children's Hospital of Philadelphia. Dr. Banwell studied medicine at the University of Western Ontario and then did residency in pediatrics at Western and then child neurology at the University of Toronto. She then did a neuromuscular fellowship at the Mayo Clinic in Rochester. And I don't know if Brenda will be talking about how she moved into MS later on. But she eventually rose to the rank of full professor at the University of Toronto, and then was recruited and relocated to the Children's Hospital of Philadelphia in 2012. So just on a personal note, Dr. Banwell has been a mentor and a colleague to many of the neurologists and other people at CHIO. And so we are really pleased to have her. She is the triple threat. She's a very well-respected clinician. She's a superb teacher, as those of us who trained under her know, and she's a world-class researcher. So we're very pleased to have her. Again, as we were talking about before, it'd be nice to have you visiting in Ottawa in person, but we'll save that for the future, but we're very happy with the virtual presence today. So thank you, Brenda.
Thank you, Asif. And can you hear me well? Great. So to all of you, many of whom I have had the privilege of working with, being friends with, colleagues, and have shared a great deal of my career with, it's really an honor to be selected to give this lecture. Peter and I realized just how long we've known each other. Which considering I remember Peter being one of the leaders in the field when I was training, and I remember discussions amongst my peers, Don McGregor and others, and fond memories of knowing just what a warm and welcoming community child neurology in Canada really is, and certainly that's been my experience from day one. So I think carrying forward One of the greatest joys as a clinical researcher and as a member of faculty is the excitement and truly innovative opportunity to mentor those coming forward in the field. So I'm looking forward to the presentations that are going to come from the trainees after my talk. I looked at the titles. It looks like it's going to be a great morning. I'm excited to hear your work and provide any thoughtful feedback that might be of value to you as you look at your career. So I'm going to share my screen. And all right, I'm hoping you are all now looking at my lead slide. Is that correct? Terrific. All right, so I'm going to spend some time this morning sharing with you one facet of a collective body of work that I have had the privilege of being part of in collaboration with many, including Asif and Sunita and Danny, all of whom have been pivotal at the CHIO site in particular. But this represents a body of work that spanned all of Canada and then the Children's Hospital of Philadelphia as well. All right, if that works. There we go. These are my disclosures. I have served as a central imaging reviewer for the first full phase 3 clinical trial in pediatric MS. I do provide non-remunerated advice on the safety of clinical trials for pediatric MS patients and on the conduct of those trials as they move forward. Our goal for the morning is to talk about some of the clinical features and diagnostic criteria for multiple sclerosis in children. I will share some of our neuroimaging, both routine clinical imaging insights, as well as more research-focused imaging on the impact of MS on the developing brain. And then I'm going to talk about a relatively more recently recognized inflammatory disease of the central nervous system, referred to as myelin oligodendrocyte glycoprotein, or MOG associated disease, MOGAD. I want to start where it began and make sure that right up front, I highlight just a number of people that have contributed to this. And here in the corner, I have listed the Canadian Pediatric Demyelinating Disease Network, of which several of you have been a pivotal component over the years. This body of work included 23 sites across Canada, all 17 pediatric hospitals, as well as centers that were distant from a pediatric site, plus CHOP. We were fortunate to be funded for this work since 2004 and continuously since, which has enabled us to do a truly prospective, comprehensive, cohort-based project, many aspects of which I'm going to share with you this morning. I highlighted and read the imaging team because I'm going to be speaking predominantly about imaging in this presentation, but that's not to in any way downplay the enormous amount of effort that my clinical colleagues, neuropsychology, cognitive sciences, clinical basic science, genetics, and immunology, all of which are part of this larger project. So I think one of the questions Asif asked me is, how did I move from looking after children with muscle disease into a career that has focused so much on inflammatory brain disease? And the answer really is where it always should start, which is with a story, with a patient. And my journey into the demyelinating field started with taking over the care of an 8-year-old boy who presented with a first attack of what ultimately was shown to be multiple sclerosis. And we refer to these initial attacks as an acute demyelinating syndrome, or ADS, a first demyelinating event. And his parents asked quite straightforwardly, what does this mean for my son? Is this a one-time experience? Is this a lifetime disease? How do you know? Is he going to be okay? What treatments can we use? And in 1999, as I was just sharing with Dr. Humphreys, that entire literature review took me less than a day to do. The literature on treatment for pediatric multiple sclerosis was a single case report of a little boy in Great Britain who had been treated with beta-seron. And the prevailing sense in the community at that time was that multiple sclerosis probably didn't happen in childhood. If it did, it was distinctly different from adult onset disease. There were no criteria for the diagnosis of pediatric MS at that time. And literally everything that lit up on brain MRI was called ADEM, acute disseminated encephalomyelitis, and we had to work from there. So my journey into this field was one of necessity. I had a responsibility for this little boy and then 4 others that soon came to be under my care, and I really didn't know how to look after them. And I didn't have the knowledge base to really provide evidence-based care. And I had a division chief who understood that and empowered me to go ahead and create a program, even at that point, for what looked like a very small number of patients. And I joined, in addition to the child neurology community in Canada, I joined the MS community in Canada, and every door opened. Every project that we wanted to do collectively, every group of people across the country were welcoming and inclusive. And as I was also mentioning to Dr. Humphreys, one of my first lectures was actually in Ottawa. In fact, formally, my very first faculty lecture ever was in Ottawa. I was invited to give a lecture on pediatric multiple sclerosis. My clinic had been open 2 months. I had absolutely nothing meaningful to say. I couldn't put together a slide deck. I wish I had it now. It would be really appalling. But I couldn't put together a slide deck with enough information to fill an hour. I was absolutely terrified that I would not have enough to say. But it was the beginning and the thing that I think is also important to all of you who are trainees, which is when you do something new and people welcome you and give you opportunities and highlight that you're there and enthusiastic and working hard, this is how we create a bigger community. And that is exactly how my career started. So I'm hoping I can do a little bit more fulsome a presentation than I could 22 years ago. And a great deal of what I'm going to share is indeed because of that community. So this is where it begins with a first attack. So as shown on the far left, the first event of an acquired demyelinating syndrome might be myelitis. Here there's a small focal partial myelitis lesion in a child for whom this was their first MS attack. It may happen in the brainstem, and as you can see on the bottom left of the screen. We may see children with optic neuritis as illustrated here, and I'm hoping my arrow is pointing as well as the red arrows. Here is a patient in the middle with acute disseminated encephalomyelitis, or ADEM. ADEM is defined clinically by the presence of encephalopathy, which is required, as well as polyfocal deficits. And that's extremely important. If the patient is not encephalopathic, they do not meet the criteria for ADEM. And the reason for that is so that we don't lump this patient here with ADEM with this patient on the bottom right. The patient on the bottom right is a 14-year-old boy who presented with his first MS attack. He came in with hemisensory deficits. He had 179 discrete lesions on his MRI at first presentation, illustrating that there's a subclinical phase of this disease that can be clearly long enough to have acquired an enormous burden of disease. But if you look at these two images, while there may be those in the room who can say they can tell the two apart, they look a little different. Quite honestly, in 1999, both of these MRI scans would have been labeled as ADEM, and parents would have been told that their child probably had a one-time event that was likely to be recovered from without any long-term consequences. Clearly a very different prognosis, because the patient here with ADEM does indeed improve, and she was back to normal in about a week and a half. Whereas my young man here on the bottom right, an African-American youth in Toronto with highly aggressive MS, had a very different future. So this is where it all begins. So let's start with one of my patients. This is a 15-year-old, previously healthy young lady, no prior history of any transient neurological deficits. 2 days prior to presentation, experienced a lightning bolt sensation with forward neck flexion, which is referred to as Lermite's symptom. She noticed that her right hand was clumsy, and she had difficulty using it, almost a useless hand syndrome. She couldn't get the hand to do what she wanted it to do. She was a non-smoker, but she did live in the home of a father who smoked. And there was no family history of neurological disease, and certainly no family history of autoimmune disease. It was her image I showed you on the prior screen. So she has a focal myelitis lesion here, which you can see demonstrated in axial view here. She has a brain MRI that shows both very clear focal lesions that are discrete, juxtacortical lesions, as well as periventricular involvement, both in very discrete lesions, but also this hazy white matter appearance here, which is confluence of prior focal change. So for example, if you can see here, there are multiple smaller discrete lesions that have started to coalesce. And you can see one in the corpus callosum here that isn't quite yet joining into this area of ill-defined white matter. So even though we were just meeting this young woman, she shows us that her disease has been marching forward subclinically for some time. Her spinal fluid demonstrated 5 IgG bands that were not present in serum. So this is a positive oligoclonal band finding in the spinal fluid, which means that she has been making intrathecal immune proteins that are not present in circulation. This is a finding that we see in adults. About 90 to 97% of adults with multiple sclerosis will have oligoclonal bands. Slightly lower rates in children, but very commonly seen in MS, not specific. You can see oligoclonal bands, for example, in patients who have had prior measles exposure and now come in with SSPE, subacute sclerosing panencephalitis, will have, for example, oligoclonal bands. So they're not specific, but in this context, these are highly suggestive of multiple sclerosis. She also had what I won't have time to go into today, but which relates to risk determinants that are relevant for multiple sclerosis. So she did indeed show that she had had prior infection with Epstein-Barr virus, which is a very common risk factor for multiple sclerosis. And there are even some that will say that if you are EBV negative, you don't have MS. I'm not sure we can be quite that provocative in that statement, but 99.5% or so of adults with MS are EBV positive. And the vast majority of pediatric patients, well over 88%, are positive at onset as well. She was vitamin D insufficient, also a well-recognized risk factor for multiple sclerosis, as well as a risk factor for other autoimmune diseases, and an increasingly common problem in Canada, potentially contributing to why we are one of the world leaders in the rate of MS, and perhaps something we might want to think about at the community level to mitigate this risk. And as I showed you, she had a spinal cord lesion. She was not acutely ill. She did not have any biochemical or chest X-ray findings of sarcoid. Her workup for other autoimmune conditions was negative, and she did not have antibodies to aquaporin 4 or MOG. So she very clearly meets the 2017 revisions of the criteria for multiple sclerosis. In this revision of the international criteria, we included that oligoclonal bands could be used to demonstrate distribution or dissemination of disease in time. In other words, you've got something going on that's chronic enough that you have CSF oligoclonal bands. Not in her case, but in some patients, focal cortical lesions can be added to the criteria for distribution of lesions in space. So in multiple sclerosis, the word multiple and sclerosis, multiple plaques, means that you have lesions distributed in the central nervous system. So, and in a distribution that is typical for multiple sclerosis. So juxtacortical lesions, periventricular, infratentorial, or spinal cord are the 4 areas. And this young woman had 3 of those 4 demonstrated on her MRI: spinal cord, juxtacortical, and periventricular. Previous criteria for the McDonald criterion had this very complicated algorithm to remove lesions that were acutely symptomatic and to look at the non-symptomatic lesions. In the 2017 criteria, we felt that was onerous and did not improve the sensitivity or specificity, and we took that out. So now all lesions count. We also very clearly made the point that the criteria for multiple sclerosis are age span wide, with one caveat that I'll get to in a moment, but otherwise the criteria for MS apply to children as well as adults. And we can make the diagnosis of multiple sclerosis at the time of a first event if the patient has imaging features that meet these criteria. But you can't just say that, you have to show that. And this was a project that we did to evaluate whether or not the 2017 criteria really do apply well, apply well in the pediatric context. So we took 324 of our prospective cohort 71 of whom were clinically relapsing remitting MS, and 253 who were not. As is typical in a pediatric study, mean age was about 10. And we had almost 3,000 MRI scans as part of our study to evaluate. We also had oligoclonal bands, and we sent uniformly all samples, because our biobank now includes, I think, about 40 to 50,000 aliquots, and we were able to analyze all of our participants for AQP4 and MOG in a rigorous manner. I'm not going to expect you to look at this, but the key determinants that identified an individual child at first event who was experiencing what was their first MS attack, as compared to patients who were going to have a monophasic disease course or a non-multiple sclerosis disease course, were the following. So the presence of a black hole, and I'll show you a picture of one of these in a moment. In other words, a T1 hypointense lesion. If that's already there when you present with your first event, you've had enough time to have a focal area of permanent tissue injury. And not surprisingly, that aligned with the diagnosis of a chronic disease like multiple sclerosis. Lesions perpendicular to the major axis of the corpus callosum. These are Dawson's fingers. I'll show you an image of what those look like. These are the flame-like lesions that emanate out from the corpus callosum and are very, very common in MS. Enhancing lesions are common in multiple sclerosis. Breakdown of the blood-brain barrier and inflow of activated circulating immune cells is the hallmark of the inflammatory aspect of this disease. Going against the diagnosis of MS was the absence of periventricular lesions. Going forward for the diagnosis of MS was the presence of oligoclonal bands, as I've just discussed. And very much against the diagnosis of MS is the presence of antibodies to MOG. So we took this cohort and we evaluated the various criteria. I'm not going to go through all of them today, but just to highlight the 2017 criteria that we were discussing, and applied this to the patients that we had studied. And we found that the criteria performed pretty well. 71% sensitivity, highly specific, strong positive and negative predictive values. And this 71% is very similar to what you see when you apply the 2017 criteria to adults. So these criteria work well, and they work similarly to when they are applied to the first attack of MS in an adult cohort. What we also found is that there are two particular criteria that very, very strongly identify someone experiencing their first attack, at least if they're a child. And as I mentioned, this was the presence of a periventricular lesion here with the orange arrow, and these are black holes. So there's one here, there's another one here, there's a very well-defined one here. And when these are present, and particularly these two criteria together, we are very good at identifying that this child has MS. And so I would encourage you to think about that, because these are quite readily applied on routine clinical imaging. So why do we study pediatric MS? Among many reasons, in terms not only to apply better clinical care and provide more accurate and prompt diagnosis, there's also a lot to be learned about the biology of multiple sclerosis when you study the youngest patients. So in this graph in yellow, the typical clinical course of multiple sclerosis is diagrammed. So in the first part here on the far left, there's a flat phase of preclinical disease activity. We don't know how long this is. If you are an 8-year-old with multiple sclerosis, by definition, you can't have had too many years of subclinical disease. It's entirely plausible that this subclinical phase in adults could span a couple of decades. And I say that because the epidemiology of multiple sclerosis suggests that you acquire your MS risk as a child or as a teenager, but certainly well before you become an adult. And again, I can answer questions on that point, but the data really strongly suggests that your MS risk determinants are acquired in a window of risk in childhood and early adolescence. As such, if you have your first MS attack when you're 38, you've had a long time of subclinical disease activity that may have been very low level before your first event. Children, by definition, have to have a shortened level. And perhaps that might be sort of a clue that they have more aggressive disease, or at least more active inflammatory disease. If the subclinical stage is short, their relapses, children have more relapses in the first couple of years than adults do. So I think they have a shorter subclinical phase potentially, although of course I can't prove that, and then multiple of these relapses early in the disease. For years, we conceptualized multiple sclerosis as having predominantly a peripherally mediated inflammatory injury, so activated immune cells gaining access through the vein into the brain in these perivenular plaques, and then a later sort of intrathecal degeneration and smoldering inflammatory biology. What I hope to convince you of by the end of this presentation is that maybe some of this degenerative biology actually is present from the beginning. We could even conceptualize that it may be the inciting event. Certainly, children are the way to look at this. I will show you some evidence that this degenerative biology is not a late phenomenon of years of inflammation. And I'll start with one line of evidence to support that statement. So multiple sclerosis occurs, of course, during a window of time in childhood where you're expected to have age-expected brain growth and then other maturational changes in the white matter. So we used our prospective serial imaging data to evaluate the rate of growth, maximum brain size, and brain volume changes over time compared to a National Institute of Health normative aging study. When we started our Canadian study, we knew that the NIH was going to do this prospective study of healthy children. And so we aligned our imaging protocol to enable us to partner with them for this particular analysis all those years later. So in blue, there's about 565 healthy children in the NIH cohort. In blue is the brain volume change from 5 to 20 in healthy boys, and in green in healthy girls. In our cohort of boys with MS and red and girls with MS in purple, we can see several critically important findings. Number one, as early as we measure it, the brain volume of pediatric MS patients is below age and sex matched expectations. They start off with brain volume loss already. Second, if you look at the rate of growth expected, pediatric MS patients do not have age expected brain growth. Quite worrisome, by mid-adolescence, the difference between age maximum brain size in boys, the difference between blue and red, and girls, green to purple, is enormous, meaning that children with MS do not achieve maximal brain volume. And then after midpoint of adolescence, we have frank atrophy. There's brain volume loss in the girls and brain volume loss in the boys, whereas in healthy kids, there's a very, very, very slight rate of brain growth into our 20s. And then unfortunately, we all start losing brain volume after 20 at a very low rate. But boys and girls with MS lose brain volume very visibly and at a much more accelerated rate well before their late adolescence. When we looked at the thalamus, which shows a very, very minimal rate of growth normally throughout childhood, it's already a pretty robust size relative. This is normalized thalamus. So this is normalized to the size of the head. So in other words, the thalamus is growing pretty much like the brain is growing normally, except in people with MS, and both boys and girls, it is simply going down in size from the minute we measure it. And we're not the only group to show this. The Italian cohort study using different methods, which is helpful to show that that finding is substantiated not only in an independent cohort, but using a different style of analytics, if you will. So they here were looking at which regions in the brain best differentiated youth with MS from healthy youth. And as you can see in yellow, the thalamus was by far the structure most affected by multiple sclerosis in pediatric patients, which is our finding as well. And it matters. So when you lose thalamic volume, you have an impact on cognition. And this illustrates the relationship between low thalamic volume and reduced full-scale IQ in our pediatric MS patients, a relationship that does not exist in healthy kids, at least not statistically, because presumably they have perfectly healthy thalami, and therefore there's no relationship between their thalamic volume and their IQ. But in children with MS, unfortunately, one of the potential correlates of the cognitive impact of MS is the reduced thalamic volume. So why the thalamus? And we have looked into this for a few reasons. One, we thought it would be interesting to see if there's a biological reason for why the thalamus might be preferentially negatively impacted by disease. And one important note is that the thalamus is an interesting structure because one half of it is bathed in CSF and the other half of it is surrounded by white matter. And so with that in mind, we wanted to ask the question, well, is there something in the spinal fluid? Is the CSF toxic? And if so, maybe there's a differential effect on the CSF facing side versus the white matter side. Alternatively, since MS does indeed damage white matter tracts rather dramatically, and there's white matter volume loss, maybe the input on the thalamus would be greater on the side facing white matter. So we used a voxel-based measurement to look at each voxel in the thalamus, each little tiny square, over time, using a Jacobian determinant to see which part of the thalamus was changing over time relative to age-expected, sex-matched thalamic volume change over that same age span. And we computed this difference from the CSF side and from the white matter facing side to see what pattern of volume loss we were experiencing. So to orient you, the red line is normal growth. So these are healthy children and what they should do over time. The graph now is looking at the distance of the tissue from spinal fluid. So here on the left, we're looking at the CSF facing side. And then over here on the right is in millimeters, 12 millimeters out. This is the edge of the thalamus facing white matter. And blue are children with MS, and in green are the patients that have had a single demyelinating event, but no further attacks and no new brain lesions. And this was done with patients with a minimum of 5 years of observational follow-up and research clinical and MRI visits. So on the white matter side, both the children with MS and those with monophasic demyelination have deviated from thalamic size compared to normal and thalamic growth. So there is a hit on the white matter facing side in anybody who's experienced demyelination. But only in the MS patients is there a failure of thalamic growth in the side facing spinal fluid. Monophasic patients do not show this. So this was very interesting, and it goes along with pathology studies, autopsy studies in adults, where there is extensive subpial cortical volume loss in MS patients as well. The cortex bathed in CSF, they've even looked at whether in peaks of a gyrus versus the valleys, and showing that the more CSF facing the cortical tissue is, the greater the negative impact in terms of cortical volume loss and intracortical pathology, raising the very interesting but still to be substantiated hypothesis that maybe the spinal fluid in patients with MS has something within it that is damaging to tissue. We are now extending this work to the caudate, and of course, very interested down the road in looking also in the spinal cord. So moving on, we know that the white matter is injured in MS. That is indeed the hallmark of this disease. But what about white matter more broadly? And to look at that, we have used diffusion tensor imaging, which for those that aren't imagers is a technique on MRI that allows us to look at tissue alignment. So if you looked at a completely free space like water, CSF in the middle of the ventricle, the fractional anisotropy, or the extent to which something is aligned, is 0. It's not aligned at all. Free water, hydrogen could go anywhere. If you had a lead pipe that you were imaging, the fractional anisotropy would be 1. Every bit of that structured tissue is in the same direction. And in the brain, obviously in the white matter, we have tissue going in multiple directions. And so the fractional anisotropy numbers vary between 0 and 1. And so what we did in this particular project was to look at the non-lesional white matter. So now we're asking the question, is the white matter just abnormal in children with MS and children with monophasic demyelination, even if it's not those bright T2 spots that we see so clearly on MRI? What about the rest of the white matter? And does the white matter mature the way it should? So this disease hits at a very young age. What happens to the normal maturation of white matter that is actively ongoing into our early 20s? So here are our healthy participants who have undergone multiple imaging study time points over the years. And I'm going to focus here on fractional anisotropy. I'll leave diffusivity aside for simplicity's sake, but here we're talking fractional anisotropy is a good measurement of tissue alignment. And what you see is that the white matter over time in healthy boys and girls shows an increasing fractional anisotropy or increasing FA, consistent with pruning and organization and maturation of tracts. The white matter is better aligned as we acquire more myelinated white matter, and as that white matter is more definitively sort of aligned into specific tracts. In our children with monophasic demyelination, and again, these are kids who've had no new lesions over time, but they did have a first event, we see that there's a bit of a deviation from healthy youth, but this was not statistically significant. Our MS patients, on the other hand, go in the wrong direction. So over time, their white matter becomes less well aligned. So not only do they have focal pathology, they have a global pathology. Their white matter is not normal. When we looked a little harder, we thought, well, let's break down those monophasic patients into two groups. We looked at those in yellow who had a monophasic demyelinating event, optic neuritis or spinal cord involvement, no brain lesions. So they had a demyelinating attack, but it didn't hit inside the central nervous system brain. It hit the optic nerve, central nervous system, optic nerve, or spine. And they had normal white matter maturation. Those children who had a first and only event that had brain lesion pathology, they looked a lot like MS. And the obvious question is, maybe these people in the pink are really undeclared MS patients that have had no new lesions and no second event yet, but maybe we will, as we follow them into adulthood, learn more. We know they haven't had anything new yet, and their MRIs have been completely quiet in terms of new lesions, but this is a worrisome finding, and they are tracking like an MS patient. So we talked about the white matter being a big part of MS, but it's not the whole story. And as I told you, in autopsy series, we see quite a bit of cortical pathology in MS. But obviously, I am hoping not to see autopsy studies in any of my patients, and we're going to try to image the cortex in our patients as children. And so to do that, here we were looking at cortical involvement, and here we measured cortical mantle thickness. Not actually easy to do, but we were able to do that using quite detailed methods where we calculate every single one of these little tiny lines that are close to one another and get an actual convoluted structure into an actual computational model. And the take-home message, we found one interesting finding that I wanted to share with you that I found quite interesting, and we'll be looking at other key areas in the brain. So while this might not look dramatically different, it is indeed statistically different between healthy controls in the darker color and youth with MS, age and sex matched and corrected for both. The entire cortical mantle was thinner in youth with MS. We were focusing on the visual cortex here in this particular study because so many of our patients have optic nerve involvement, optic neuritis as one of their attacks. And we see that the visual cortex is indeed reduced in MS patients compared to controls everywhere except the fovea. So there was complete foveal sparing in youth with MS when we measure the cortical mantle thickness, raising the very intriguing possibility of a resiliency or reserve in children with MS with potentially an altered biology of foveal development in the context of this inflammatory disease. And so we are now going back to key other areas of the cortex to see whether, for example, the thumb area or very pivotal areas in the motor strip, are they also spared in MS as a potential mechanism for some of the resilience that we do see in our kids with MS who, even with multiple episodes of optic nerve insult, continue to have preserved foveal volume at least. So moving on to the next patient. This is a 5-year-old who came in with 3 days of parentally described wobbly gait. She'd had some vomiting, she'd had a little bit of being unwell, she'd had headache, and she had just generally been off, not eating normally for the last month or so before she presented. She did not want to bend her neck. When we met her, she found that very uncomfortable. She was very irritable. So she was speaking in sentences, but she very quickly deteriorated and became extremely irritable. Cranial nerves were normal. She had increased muscle tone in her extremities. She was definitely ataxic, particularly, and also had some spasticity in her gait. She had clear dysmetria and tremor. Her reflexes were brisk with sustained clonus, and her plantar response was extensor bilaterally. She had an impressive white count in her CSF, 225 cells down to 30 on tube 4. Her opening pressure was up a bit at 35. And she looked unwell and had a slightly elevated white count. Her ESR was also elevated at 45. And her serum MOG titer was positive at 1 in 1,000. So, and oligoclonal bands and AQP4 were negative. So on this slide, she highlights several things we've noticed in MOG positive children. They tend to have more cells in their CSF than we would expect to see, clearly different than normal, but also higher than we would ever expect to see in multiple sclerosis. They are often systemically a little unwell when they come in. They have a higher white count. ESR is commonly elevated, non-specifically, but it's a common association. She showed why she didn't want to bend her neck. So she has a rather extensive upper C-spine, well, entire C-spine lesion, frankly, which would explain this Lermite symptom with reluctance to bend forward due to a lightning bolt or electrical sensation down her spine. She had patchy cord involvement all the way down. I don't know if it projects well, but all the way down to the conus. And on multiple levels, it involved certainly all of the gray matter in the cord, and in some levels, and again, I'm not sure this is projecting and well for all of you, but both gray and white matter of the cord. So a very extensive myelitis. Her brain lesions, she had both cortical and juxtacortical lesions. You can see a cortical lesion here. She had deep gray involvement. She had involvement of the upper aspect of the brainstem going into, in this case, the peduncle. And she looks and is behaving very much like what we see in patients with an inflammatory disease associated with antibodies to a really tiny protein called MOG, which represents a very small percentage of all CNS myelin proteins. So it is small but mighty, at least as far as our immune system is concerned. And it is expressed on the outer lamella of myelin, so quite visible to the immune system. Of course, as many of you know, MOG is expressed in the central nervous system myelin, not the peripheral myelin. So we went back to this cohort that we had established over the last 17 years, for whom we had obtained serum that had been carefully processed, banked, and stored. So this is one of the huge advantages of a biorepository. And we were able to take those samples and have them all analyzed by Dr. Patty Waters, who's one of the group that have really optimized the MOG assay using a cell-based system with an IgG1 secondary to detect MOG antibodies. And that sentence is important, not because you need to know cell-based assay with an IgG1 secondary, but because you do need to know when you order MOG, where is it being tested? If you test MOG using less rigorous techniques, you will pick up MOG antibodies in about 25% of healthy people. And these are non-specific. They are not associated with disease. And it's one of the reasons that this whole story has taken a number of years to come forward. I mean, we were testing for MOG antibodies in 2008. And we were getting a very high hit rate when by we, I mean Dr. Bar Or and I in a group in Germany. And they weren't specific. We tried a tetramer technique to try to make a conformational MOG to get more specific, and we were able to get better, but that's not an easy assay to make commercially. And it was really the cell-based assays with very specific MOG IgG1 tagging that allowed this to become the much more specific and very rarely detected in healthy kids. So that was pivotal, and it does matter where you send your testing. So here we go. So what we found is that about a third of all of our pediatric patients with the first attack of demyelination had MOG antibodies. So first message, not rare. When we looked at the younger children, those under 11, almost half were MOG positive. So younger children presenting with an acquired demyelinating syndrome, MOG is very frequent. Much less so in the older children. And in the negative MOG group here, we have the majority of our MS patients who are in this group. MS is much less common under 11. And then, of course, in both sides of the age span, we have kids with monophasic disease, which may or may not be MOG positive, which I'll come to. Overall, 77% of our patients with MOG antibodies were under age 11. So much more common in the younger children. When we looked at what they presented with, in children with MOG antibodies, almost every one of them had involvement of either the optic nerve, spinal cord, usually in a longitudinally extensive manner, or they had ADEM. In children who don't have MOG antibodies, we get the whole array of clinical presentations, which include optic neuritis and myelitis, but also brainstem demyelination, hemisensory syndromes, et cetera. So children with MOG antibodies are highly likely to have ADEM, optic neuritis, or transverse myelitis at presentation. So here's where we also took advantage of having prospectively acquired serial samples. So we were able to look at patients multiple time points over the course of their prospective evaluation. I should mention back at the beginning, because we wanted to be very consistent, we only included patients in this study for whom we had a biological sample within 45 days of their very first neurological symptom. This is very important, as you'll see here. So first message, if you were negative and you were tested at presentation, you're negative. And none of our patients were positive later. If you were positive at baseline, 36% were positive with a median follow-up of almost 7 years, persistently, multiple time points. The majority, almost 60%, became seronegative. And then we have a small number that kind of go up and down. If you look at the graph here, you can see that people become seronegative pretty quickly. Within 2 years, the majority that are converting to become MOG negative do so promptly. So this is really important because if you meet somebody here at year 5 or 4 from when they started and you test them and they're negative, it does not mean that they were negative had you been able to test them at the beginning. And that's really important because unfortunately, this is a busy slide, but I'll explain it. What we discovered is there are patients who have relapses after becoming MOG negative, even when they were MOG positive at the beginning. So for example, here's a patient, this little row here. Each one of these lines is a patient. Dark blue is when they were MOG positive. Light blue is when they're MOG negative. And every relapse, you could, if you really want to know which one, they're all illustrated here, but every circle is a relapse. So let's look at this patient here. They're MOG positive at the beginning. They have a period where multiple time points they've been MOG negative. Every little black dot is a test point. And now they have another attack. They've been MOG negative for years and they've relapsed, but they were MOG positive in the beginning and MOG negative later. So this is really important information. Unfortunately, MOG antibodies don't always last, and that doesn't mean that you're free and clear. Becoming seronegative does not guarantee that you are free of risk of relapse, and having a relapse and being negative then does not mean that you don't have, many negatives in that sentence, that you don't have MOG-related disease. And one of the things that's important here is that the MOG antibodies are only one biomarker of this condition. There are also MOG reactive T cells, which we have a very difficult time measuring because they're in low circulation, low volume in the circulation, and you would have to obtain large blood volumes to capture them. So there's a lot more to learn here about how to really understand MOG disease. And this is just a bigger version of the same paper that's just out now in Annals of Neurology, where we've looked at every blood test, every MRI scan, every relapse, and every clinical presentation with some important messages. And I think very importantly, the value of a prospective cohort. I didn't know that these patients had MOG when we first met them. They weren't treated like MOG because of course in 2004, we had no idea they had MOG. So the other thing about this cohort, it is a largely untreated cohort unless they get into these relapsing periods. But this window of time in here, we did not treat them because we didn't know they had MOG antibodies. And the other important message here is that we did not put these patients on chronic steroids. And if you look at the literature, there are some adult centers who provide patients with MOG antibodies with 6 to 12 months of steroids. Please don't do that. Our pediatric patients, there's no evidence that our patients need that. Our relapse rates in this study were comparable, about 22%, like lifetime risk at this point up to 7 years, and that is without steroids. They had a short course of steroids, as you guys all know who've worked with me. I only use steroids for a brief period of time to get kids better out of their first event. I don't put them on chronic steroids, and none of our Canadian colleagues have done that either. And our relapse rate is not high. It's actually, if anything, lower than some of the cohorts in Europe. So I can't justifiably suggest children need 6 months of prednisone. And all of you as pediatricians know very well what the morbidity of 6 months of prednisone is to a child. Okay. The other message that we got in this particular cohort was we also looked at all of their MRI scans. And we found a few interesting things. So 20% of our patients had at least one new lesion. The new lesions in the majority of the patients were completely clinically silent. And they did not, I think this is there, predict relapses. So in the first 6 months, unlike multiple sclerosis, in children with MOG, they can acquire silent lesions, particularly in the first 6 months. And those new lesions do not seem to carry forward, or at least in this number here, with only a 20% positive predictive value. That does not mean this child is destined to have relapsing disease clinically, which is very different than multiple sclerosis. In multiple sclerosis, when you have new lesions, that's part of our criteria to confirm relapsing remitting MS. So we're learning a lot about MOG. This is one study, and there's clearly a great deal more work to do in the field, and there's an international MOG panel. That was actually my 7 a.m. meeting this morning. And we're looking at, at validating the findings from the Canadian cohort. But take-home message is we really aren't very good yet at identifying who's going to have a single MOG attack and a monophasic course, and who's destined to have relapsing disease. And some of the clues that we would normally use are not very evident in pediatrics. So I'll speed up a little. I know that it's 9:20, so I want to just make sure I finish on time. So this is a 10-year-old girl who came in with a dramatic presentation, flaccid weakness of the right arm, leg, and face, with a large hypodense lesion. She was acutely unwell, had to be admitted to our intensive care unit due to the somnolence and you'll see in a minute, extent of her lesion. She didn't really improve very well with 5 days of Solumedrol. And then on day 7, she deteriorated again with increasing somnolence. Her dense hemiplegia and aphasia were already severe, but even worse, but she was obtunded. And this is what her brain looked like. You can see initially she's got this huge tumefactive lesion that got dramatically worse in 7 days on steroids. So now she's extended her lesion, she's herniating, and went straight to the operating room for both decompression, craniotomy, and we took a brain biopsy. And her biopsy shows a variety of findings. She's got perivenular loss of myelin, which I'll show you better here on a Luxel Fast Blue, where you can see that she's lost myelin. And you can see that in the tissue here, she has multiple smaller areas of demyelination, as well as these huge areas of demyelination. She has a CD68 positive infiltrate. So these are macrophages basically. So she's got considerable macrophage infiltration. She's got some T cells with a pan T cell marker of CD3. And she ultimately had MOG antibodies. And this is one of the times where the MOG antibody came back about 2 days after the brain biopsy, which we would normally wait for the results before we would ever biopsy someone. But she was going to the operating room for a decompressive craniotomy. And this is a recognized phenotype of MOG with large tumefactive lesions. And this is not her. This is a publication of another patient with very similar features. And in that case series from Mayo, the pathology was indistinguishable from our patient, and precisely the same pattern of infiltration and demyelination. And interestingly, in their series, which included autopsies of adults, in MOG patients, they had a lot of intracortical pathology, which is a value to know and very hard to see on MRI. And we now recognize that MOG is a diverse presentation, or at least there are multiple presentations associated with MOG antibodies. We now need to know whether the antibodies are pathogenic in all of these different presentations. But we see patients who come in with an ADEM-like phenotype with widespread disease. You can see it becoming even more widespread. And these patients can develop a leukodystrophy-like clinical story. We have patients that have cortical lesions, as you can see illustrated here, multiple cortical involvement and then progressive cortical atrophy. And many of these patients present with seizures. So in fact, now if you have someone presenting with catastrophic new onset seizures, I would advocate checking for MOG antibodies. Similarly, here's a patient with encephalitis with dramatic encephalitic features, the cortical laminar necrosis that you can see here. Again, high titer MOG antibodies. And here's a patient with a vasculitic pattern. And I know if Danny Pohl is on the call, I didn't see you, Danny, but if you're on the call, you and I have shared these kids where we have looked at vasculitis as a possible diagnosis. Some of them have had brain biopsies showing vasculitis. And we now know a number of these kids have MOG antibodies. And both of us have wondered whether, had we known that, could we have saved them a brain biopsy and could we have managed them without having to do an intrusive biopsy? And then this is the leukodystrophy pattern that I was mentioning, illustrated a little bit more clearly. And I have several of these patients. And over time, they behave very much like children with leukodystrophy. So I don't know, it's particularly in this group, whether the MOG antibodies are a secondary phenomenon or a driving pathobiology. And that is the next set of things we need to learn. And that illustrates the same point. But MOG antibodies are not rare. Here's a series of patients with what looked like more of an encephalitis. And other than NMDA antibodies, the second most frequent antibody in these children was MOG. So think MOG. When you see patients with an acute encephalitic presentation, if you see patients with catastrophic epileptic encephalopathy, as well as patients that have demyelinating presentations. And this is part of a recent Lancet Neurology review that a group of us put together where we illustrate the various features of multiple sclerosis, relapsing MOG with the fluctuating antibody titers that can go to zero even late in the disease. And then I don't have time today to talk about AQP4. But I want to end with a couple of key points. So MS in children is a relapsing remitting disease. We don't see primary progressive disease. So if you see a patient with progressive neurological deterioration, think of a lot of other things than MS. MS, however, does have a neurodegenerative component as evidenced by a negative impact on brain growth, atrophy by mid-adolescence, and there's a particularly deleterious effect on the thalamus. I didn't talk about treatment today, but I can in the questions if you like. Early treatment mitigates all of the above. It certainly dramatically reduces relapses. And there's some promising, very early study from the Paradigms clinical trial that prompt effective therapy does reduce the rate of brain atrophy. Doesn't eliminate it, but it does reduce it, which we hope would have a long-term benefit. MOG antibodies identify children with a different disease. These children don't act like MS and they don't have an MS biology on pathology. It's heterogeneous, and there are many presentations now recognized associated with MOG antibodies, and we have a lot more to learn. MOG titers are not a good indicator for risk of relapse, and only 20 to 30% of children with MOG will relapse. So please do not put a child at onset who has MOG antibodies onto chronic immune suppressant therapy. We do not have evidence to suggest you need to do that. We really do need to know whether they're destined to have a relapsing disease course or not. And even silent brain lesions in the first 6 months are not a good indicator that they are destined to have clinically relapsing disease. And so we have a lot to learn about who we should put on chronic therapy, but at this point, most of us wait till we have at least a second attack to define children with relapsing MOG. So here's your quiz. In the interest of time, these are some patients of mine that I wanted to illustrate. This is a typical MS patient with multifocal lesions, as well as this coalescent of periventricular disease. This is a patient who has extremely severe MS. Doesn't look any different than this one. The number of lesions on scan is not a good correlate, actually, of the severity of disease, which is a very interesting finding that we can discuss at more length. This is a patient with aquaporin 4 with diencephalic involvement, as well as other areas of involvement. And this is one of my my MOG patients with cerebellar peduncle involvement, and then a leukodystrophy-like pattern over time. Last slide. One of these 4 patients has MS. In your mind, pick which one and see whether you were right. So it's this one. So this is a teenager who had 8 years of relapsing remitting disease and had ended up with these confluent looking white matter changes. And as you can maybe appreciate, this would be pretty tough to tell from MOG if you were meeting this patient at 16. And how would you know? And the point is you have to go back in time. We have to look at, prospective and serial evaluations, both of their imaging, spinal fluid, and MOG testing. But this is a 16-year-old with MS. This is a teenager with progressive multifocal leukoencephalopathy, or PML, from which unfortunately she succumbed as a consequence of years of suppression due to lupus. I get a lot of migraine patients, as I'm expect some of you do as well, who come in with these white spots, and a very helpful report that says scattered punctate white matter lesions in the brain, consider multiple sclerosis. And I get a frantic parent of a migraine patient calling for an urgent evaluation. And then this is press, and a 12-year-old with leukemia, hypertension, and recent intrathecal chemotherapy. So everything that's bright on T2 is not MS. And the art of this is to really put all of it together: clinical, biological measurements, and imaging. So I will end here. Thank you for your very kind attention. And if we can, I'm happy to answer any questions.
Thanks very much, Brenda. Excellent presentation. Asif, I don't know whether you want to lead the questions, and
Sure. We'll
there
just
are
maybe
some in the chat.
Right. Maybe we'll just do one or two quickly. I know we're a bit over time, but the talk was excellent, Dr. Banwell. So one question I think you sort of addressed was, the risks later on in life and any potential preventative measures. And I think you mentioned for MOG specifically, and I think you mentioned early treatment is indicated for those patients.
So I'm going to separate MS and MOG because they're two completely different diseases, and my advice is different. So for patients that meet criteria for relapsing remitting multiple sclerosis, and now with the 2017 criteria, we're pretty good at identifying, in fact, we're very good at identifying a first attack patient and diagnosing them at that time point. If they don't meet criteria then, and you follow them, 88% will meet criteria 3 months later on a new MRI, because children with relapsing remitting MS have very active disease. Every line of evidence for MS strongly indicates that the early treatment matters. You don't get the damage back over time. It doesn't repair that well in MS. So the Paradigm study, which was a phase 3 study comparing Avonex, or interferon beta 1a by intramuscular injection, to fingolimod, clearly showed a better outcome in the fingolimod study group, with a 85% reduction in relapse rate on fingolimod compared to interferon beta 1a. And the rate of brain volume loss in the interferon 1a group was about 0.8% of the brain per year. It's pretty high of loss of volume, but in the fingolimod, it was 0.4% per year of total brain volume loss. So clearly there's still inadequately suppressed disease activity, but it is favoring a more effective treatment. And I think the anti-CD20 studies that are now coming forward, the Operetta 1 and 2 studies, which are arguably going to be an agent that may be comparable to or more powerful even than fingolimod at suppressing disease activity, we're hoping will show potentially an even greater protection against brain volume loss and an even greater suppression of new disease activity. In MOG, other than treating the acute event briefly, the evidence does not support putting those children on chronic immune suppression at onset. That in fact, you would treat 80% of the patients unnecessarily if you did that. And so it would be to wait until there is clear evidence of relapsing disease clinically before starting or considering immune suppression. And the treatments that are of greatest benefit in relapsing MOG at this point, and again, there's no trial, so this is international consensus commentary, monthly immune globulin is arguably the most effective. It is certainly safe, and there's emerging data that monthly immune globulin is actually as effective, if not more effective, than any other strategy. Anti-CD20, the majority of data for Rituxan, just based on international availability, is also used, although there is some suggestion that IVIG might be better. Definitely not interferons, glatiramer acetate, or fingolimod. Those do not appear to work.
The other question, Brenda, just to go over this for one last question, is the minimum amount of time after an attack of MOG, say your first episode, that the antibodies will remain positive for. In other words, they come back, if there's a delayed presentation, could they still be negative, or
Terrific question. So we looked at samples obtained within 24 hours of presentation, 30 days, 45 days, for which we had variable numbers of patients because they were supposed to get it within 30 days. And we had a group that, you know, when we defined it by symptom onset versus when they presented to hospital, we had kind of a 2-week difference because kids are often kind of staggeringly along at home for 2 weeks before they come in. So that's how we ended up with 45 days. And then our next time point in our study is 3 months. So I don't have 2-month data. I have 3 month and 6 month, and then 12 months. And so by 6 months, 50% of those who were clearly positive at the beginning are now negative. So it's a rapid drop off over the first 6 months. And it's about 30-35% by 3 months. So if you're 3 months or more out and someone's negative, there's a good chance you missed your boat.
That's great. Well, thank you very much, Brenda. It was, again, an excellent presentation. Lots of people in the chat saying that. I do want to give everybody on the call time to take a break, go get a drink, use the washroom, because we're going to have a couple, almost 2 hours of presentations after this. And so once again, I'll thank Brenda. And if everyone, we're going to start promptly at 9:45. So we'll have about 7 minutes or so of a tiny break, and then we'll restart.
Great. And,
thank you very much, Brenda, for your excellent presentation, and it's great to see you.
Thank you very much. I appreciate it.